Good morning and Salam Malaysia Madini. Thank you for Wilayah and Selangor Anaesthesia Conference Organizing Committee and Dr. Cairo for inviting me, not as a speaker, sorry, as a moderator. I am Dr. Pang Yun. Actually, I am a pediatric anesthesiologist from Hospital Tunku Aziza, and I would like to moderate session on pediatric anesthesia. Today we have two amazing speakers. My good friend, Dr. Muhammad Lutfi Nijar, and my great teacher, Prof. Felicia Lim. So before we go into this symposium, I have a little bit housekeeping. So each symposium will grant speaker 40 minutes for their presentation. Following both presentations, there will be 10-minute question and answer session. In the last minute, a play card will signal the remaining time, and in the final 2 minutes, a bell will ring to signify the conclusion of the session. In the event of additional question, they will be addressed through virtual platform to ensure thorough exploration of the topic presented. So without further ado, I would like to introduce Dr. Muhammad Lutfi Nijar to speak on sedation in remote location. So Dr. Muhammad Lutfi Nijar is currently a consultant pediatric anesthesiologist in Hospital Tunku Aziza. He received certification of completion of fellowship pediatric anesthesia from Malaysian Ministry of Health. He underwent fellowship in pediatric anesthesia in Starship Children's Hospital, Auckland, New Zealand. He's not only a dedicated, warm-hearted colleague to work with, he is a beloved father of 3 lovely children, a great passionate teacher who holding many positions such as advanced cardiac life support instructor, basic life support instructor, and perioperative pediatric life support instructor. He is also a member of Hospital Research Review Committee, Hospital Tunku Aziza. His special interest is in pediatric thoracic anesthesia, pediatric liver transplant, anesthesia for craniofacial surgery, anesthesia for pediatric airway surgery. He has published articles as well as spoken in local and international conference, symposium and seminars. So let's put our hands together to welcome Dr. Lutfi to the floor to address his speech. Thank you very much.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and very good morning. Thank you very much, my colleague, Dr. Pang, and welcome everyone. I would like to thanks to the organizing committee for the WISAC 2023 for inviting me to share some experience and also share in particular about these topics. So the topic that they gave me many months ago, it was pediatric anesthesia and sedation in remote area. So, okay, just stay relaxed. Basically, at the background, this is my current practice, which is in Hospital Tunku Aziza. It's one of the newest hospital, and it's a very flash. Okay, it's very spacious, and we are glad that me and Dr. Pang have been practicing in this hospital. Unfortunately, but not many of us. Okay, too many work, but not many of us. But at the same time, we are glad that we have the opportunity to practice pediatrics almost more than 95% of our practice every day. So we can adjust, we can experience more regarding the pediatric anesthesia, not like other hospital. Probably pediatric services is just a small portions of the daily practice. So we move on to this topic. So basically, giving anesthesia and sedation outside operating theatre is not something that we are comfortable for most of us. Even for ourselves, we are dealing the additional thing that we are dealing here. We are dealing with pediatric patients. Okay, most of us sometimes feels, you know, when we start with the pediatric, we start with a negative. Oh, another pediatric patients. Okay, I think it's probably true for me as well at the beginning, but now I'm okay. All right. So what is anesthesia and sedation outside operating theatre, which is the It is an administration of sedation or anesthesia to patients undergoing painful or uncomfortable procedures at off-site location is referred to as non-operating room anesthesia. So NORA is a concept that they have been repeating for this anesthesia outside operating theatres. So look at these pictures here, and we wish that all the facilities or the locations that we have to conduct anesthesia or sedation is just at the same floor, okay? But it's not for everyone, okay? So the oncology, the angiography suites, the intensive care. So when we do anesthesia outside, the thing that we are scared is to get help, so something happen, okay? So there's a lot of challenges when dealing with this anesthesia or sedation outside operating theatres. So about 25% or 30% of our regular pediatric anesthesiology practice is comprised of NORA. Okay, and NORA is more commonly required for pediatric patients because they are not cooperative most of the time, and the cases are complex, and they tend to have complications when we give them sedation or anesthesia. And what are the challenges for pediatric NORA? First of all, it is out of our comfort zones. Okay, it's not something that we are doing it every day, and the staff, equipment, and also help for in case of emergency, not readily available. And risks and complications due to adverse events are potentially higher. When, for examples, when you are dealing with in MRI suites where they, just patient just suddenly disappear in the tunnel. How can we, if we want to anything happens, any emergency, it's not something that we can easily access to the patients. We have to wait until the scan stops, and then we have to be careful with the magnetic areas. So it's a bit complex. So patients with multiple comorbidities and syndromic, and most of these patients going for procedures outside operating theatres, for example, in imaging, they don't have established diagnosis, but they are sick. They have syndromes, they are sick, okay? Higher risk, which is anatomical and physiological variation. So in pediatric patients, they come from small until about 80 kilos, okay, from 2 kilo, 1 kilo to 80 kilos. This variation is something that we need to take care of. So it's growing sensitivity to the pain when the patients or pediatric patients come multiple times for the treatment. They have multiple procedures in the past, so they have experience, they have memories. So there's another procedure is a bit challenging. And also new interventions, okay, advent of new interventions. So more and more advance in technology, more procedures. So we have to keep up with the advance in the procedures. What are the challenges? Communication issues, and sometimes like telco or line is not good. And sometimes kita nak check, if you want to check something, you want to refer something on the internet, it's difficult. You want to call for help also, line only 1 bar, sometimes no line at all. So it's a bit scary. Okay, and frequent malfunction and interference, for examples, MRIs, okay. So you have monitors, you have MRI compatible monitors, but the ECG is not right. Okay, ECG is not that reliable. SpO2 monitoring sometimes interferes with magnetic fields. And undiagnosed myopathies and neuropathies, as I mentioned before, they don't have established diagnosis. And inadequate procedure preparation and radiation hazard to the personnel. Looking at that, this is a landmark study done by Cravero and published in 2019. They look at the incidence and adverse events among 49,000 pediatric patients who receive sedation under propofol. So what they look at is, although no death occurs, but cardiopulmonary resuscitation CPR was required twice, and there were 4 cases of pulmonary aspiration. And airway-related complications were more prominent and affected in 1 out of 65 sedations. And 1 in 70 cases required intervention to rescue the airways. Although the data suggests that pediatric NORA by well-trained personnel is rarely accompanied with major morbidity or mortality, but the complications did happen. So in particularly when we use propofol. So what they recommend is the presence of skilled anesthesiologists capable of managing the airway, to rescue the airway during these adverse events can prevent the catastrophic outcomes. And despite the presence of anesthesiologists during the NORA, and the rate of morbidity and mortality increases if the supporting personnel in the radiology and endoscopy suites are unfamiliar with the requirements of anesthesia. What are the goals of pediatric sedation and anesthesia? Basically, the first one is to guard the patient's safety and welfare. Okay, and second is to minimize physical discomfort and pain, to control anxiety, minimize psychological trauma, and maximize the potential of amnesia. To control behavior and movement to allow for the safe completion of the procedures. We want to make sure that the procedures just happens at once, because we have a lot of cancellation regarding the fail of sedations. Okay, for us, failure is not acceptable, because if it's a non-anesthetist giving sedation, there's a higher rate of failure. But for us, they refer to us, okay, because of failed sedation 2 times, they refer to us for anesthesia. So we have more options. So so we want to make sure that all the procedures, all the planned procedures can be completed successfully. And the last one, the goals is to return the patient to the state in which the discharge from the medical, which is safe to be discharged from the medical supervision. And these are the common NORA locations, basically in GI and bronchoscopy suites. We do diagnostic and foreign body removals, percutaneous endoscopic gastrostomy, and in oncology and radiotherapy is quite common for the cancer patients, like brachytherapy. It's a bit painful procedures, but need the patients to be stay still during the procedures. Imaging suites, CT, MRI, ultrasound guided biopsies, cardiac and neuro intervention cath lab, and diagnostic procedures, for example, in the ward, lumbar punctures, bone marrow aspirations, and simple procedures like EEG and also echo, and daycare procedures, dental or ortho procedures, and burn dressings, and dermatological procedures, for example, wart and mole removal. And just to mention that I've been practicing pediatric anesthesia as a full-time for the last almost 8 years, and I've been to a few places where all these areas, all these locations are quite far from the main operating theatres. But we are very fortunate in Hospital Tunku Azizah. Almost everything is in the OT itself. So we have a neuro intervention angio suites in the OT itself. We do the bronchoscopy, we do the GI endoscopy in the operating theatre itself for the pediatric patients. What are the anesthetic considerations? I can divide it into these categories: the patient, staff, procedures, and equipment. Okay. So basically, we have to select appropriately. Okay, we have to have a proper patient selection. Which one is suitable for general anesthesia? Which one is suitable for sedations? If we think there's a small issue, if we give sedation, there's a small issue, don't be scared to just give anesthesia, general anesthesia. We want the patients to be safe. We want the procedure to be completed at once. Okay. And the complete medical background, sign and symptoms of the current illness is quite important. And the previous anesthesia, history of previous anesthesia, surgery, and also allergic history. And the current medication is important. If the patient, for example, epilepsy, they might have a lot of anti-epilepsies, and including benzodiazepine, we might consider, might need to adjust our sedations or medications. And in sexual investigations, for example, renal function tests, sometimes our procedures involve contrast, and some of our medication also affected, it will affect the renal functions. And last meal is important, and vital signs and weight is important, and also airway assessment. Additional things regarding the pediatric patients, it's not just airway. If you see the patient have a difficult IV access, and almost everyone comes coming for procedures, they have lines, but lines is like half functions. How can you give sedation with lines half function? Halfway through, they will wake up. So you have to choose. It's not just assessing the airway. Another thing to consider is, this patient have difficult IV access. So what you need to do, you need to do a bit more preparation. Need to get an ultrasound. Need to get a guide wire probably. Need to get a extra senior personnel as the anesthetist to help you out. Okay. So fasting time is the same as when the patient's going for operation or anesthesia. And informed consent is important. Sometimes we have to explain. We have to explain regarding what's the procedure like and what's going to happen during this procedure, and what are the available options for sedation of general anesthesia. And we have to explain the risk as well, according to the patients. And for staff, okay. Procedure in remote areas normally associated with higher morbidity and critical incidents. Normally is the human error, and if we don't anticipate, if we are not that vigilant, we don't anticipate problems, and we don't look for it. Sometimes we just miss this, and then everything goes so far away, and patient will deteriorate. So we need someone that really vigilant, and also ability to handle the crisis, and also trained and skilled assistants. So adequate skills in airway management and also ability to intervene when required is a prerequisite for the anesthesia provider delivering NORA. So for anesthesia staff, they have to be trained and experienced regarding the anesthesia in NORA, and also airway management, CPR, and also familiar with the anesthetics and resuscitation drugs. For the non-anesthetic staff, sometimes in a remote area, we only have few, probably one anesthetist and one MOs and one assistant. But sometimes the recovery area is managed by the local staff, which is like radiological staff or angio suite staff. So they have to be trained as well. They have to be informed regarding the patient's conditions and what are the concerns regarding the patient. So this is to ensure that the patient safety. And for the procedures, so we have to have, for anesthetists, we have to have a good communications with the physicians, with the surgeons who are doing the procedures. We have also to know and understanding about the procedure itself, what's going on, what stage of the procedures, what is required for the procedures, and the nature of the procedures, or any special requirements that will influence our anesthesia. For example, patient positioning during the procedures, and the durations of procedures, and any associated pain during the procedures, and possible side effects, for example, like a contrast toxicity, and also anaphylaxis from the contrast, and equipment and device to be used. It is important because if you don't understand about the procedure, sometimes we don't prepare enough for this particular procedures. So equipment and requirements for NORA, basically equipment and monitoring standard must meet almost meet the main OR requirements. Okay, and appropriate size device and adjuncts for pediatric age group need to be available. And also the anesthetist must be familiar with the equipment in the remote setting. So it is good that we just go down to the area if we have, for example, we have elective case tomorrow. Sometimes it's good that we come early and check with the equipment yourself, and then you can detect what is available, what is not available, and then you can work for it. These are guidelines for ASA minimal requirements at non-operating room locations. Basically, you have to have oxygen source, and scavenging waste gas scavenging unit, standard monitoring, electrical outlet, and the important thing is the lighting. When you're dealing with the pediatric patients, especially, and lighting is important. And most of our CT scans and also MRI, sometimes the lighting is a bit dim, so you will struggle to get lines, as small babies, if the line is not working. So you have to find out about this lighting. Lighting need to be adequate. Excuse me. And staff trained to support the anesthesiologists, and we have to have emergency cart, self-reflecting bags, emergency drugs. And defibrillator normally we put outside the MRI rooms, and reliable source of communication to call for help. So if it's not line is not working, so you have to have a landline, available line just in case we need to call for help. And post anesthesia care unit or recovery unit. And just want to highlight here, and if in the remote area, if we have all the standard monitors available, but one of the most important that sometimes we don't have is a capnography. When you give sedation, when you give anesthesia, so capnography is one of the most important thing, and it's a very useful monitors to see whether these patients, going to the trade and suddenly you lost the capnography, or pressure, probably patient, apnea or hyperventilate. So other monitors are important, and also the transport capability also, and for oxygen tanks, and also portable monitors. And for the MRI, in particular, they have to have a special equipment which is MRI compatible. And I just want to show, this is our setting in Hospital Tunku Azizah. Basically, we are very lucky that on the first diagram, on the top one, top left, this is our induction room in MRI suites. And we have one portable GA machines outside our MRI suites. Inside also we have one, which is MRI compatible. But this is very useful when dealing with pediatric patients, which is the light is much better here. And also when we are outside, we don't have to think about all the projectiles, metals, things. Just set the line, take your time. So we are quite lucky to have these extra GA machines. And this patient in the middle, I just did on Tuesday, where just a monitored sedation using propofol infusion for imaging for the lip venous malformations. But the airway was okay, and it was successful. These are our MRI suites on top of this one. And we have this box here. They call it Agilia Guard. So our infusion is not MRI compatible, but once we bring the infusion inside, we just straight away put in this box. It will protect them, make sure that the infusion pump is okay. And this is our GA machine inside there. And you can see here, there's a lot of anesthetic personnel here. We are quite lucky at the moment. We have a few doctors, specialists who attach with us, but normally we are alone. Okay, we are only one or two of us go there with one MAs. But recently we have a few doctors who attach with us and want to have experience in terms of pediatric anesthesia. And we have monitors here inside the monitoring room. So equipment check is important. We have to have a chart, a checklist should be available at different locations. And routine maintenance and service is mandatory, similar to in OR. So for conduct of anesthesia, so we have to tailor our plans, tailor our medications according to the condition of the patient. So a lot of the patients have comorbids, and we have to tailor the anesthesia or sedation according to the procedures as well. And what are the drugs available, and also which one is our comfortable. If you're not comfortable giving sedation, we are not familiar, we just do a once a year, just go for general anesthesia. Don't hesitate to give anesthesia to pediatric patients. So it depends on our experience and expertise. And what's the contraindication for sedation? Basically, airway problems. If we anticipate during airway assessment, there's a potential or actual or potential airway obstructions. Patient with a history of apneic spells, and this is probably related to brain damage and also prematurities. And patient with respiratory distress, okay, respiratory failure, poor cough and gag reflex, they are contraindicated for sedations. Patient with epilepsy, uncontrolled movements, and also patient with full stomach, and which has a risk of aspirations. So not all patients need sedations. Small babies, we can do fit and wrap, and this is a lot of physicians with a non-anesthetic do in babies for the MRI, because MRI takes longer time, so they can fit the child and wrap the child comfortably, so they can sleep for about 45 minutes, 1 hour. Okay, so they can complete the procedures. But most of the patients like this, They just come, cry, see strangers, don't want to cooperate. So we need to give some sedation. And this is another thing. So you see here, this is the range of patients that might cause problems. Okay. So how do we do about this? Apart from anticipating difficult airway, we also anticipate difficult IV access. So you need someone to help you out. Okay. So GA versus sedations, this is just a crude rules. If the patient is more than 3 years old, or more than 10 kilo, no comorbidities, you might consider sedation. If it's less than 10 kilo or less than 3 years old, with lots of comorbidities, just go for general anesthesia. So we have full control of these patients. Okay, we go to drugs of sedations. There's a lot of drugs. Okay. And what are the characteristics of drugs that's suitable for sedation? First is rapid onset. And second is rapid clearance, minimal side effects, and combinations are easy to titrate. Combination agents to provide analgesia, amnesia, and hypnosis, and have a rapid and complete recovery at the end of procedures. Okay. See at the top there, and midazolam is the old drugs and one of the common drugs used for sedations. But for us, pediatric anesthetists, we don't like it so much because we have other things. We have other options. Why we don't like midazolam, I will tell you a bit later. So we have a range of a dose, and these are some of the guidelines you can refer to here. So we use quite a lot of propofol, ketamine, and dexmedetomidine. Okay. And sometimes we use the combination of ketamine and propofol, which is ketofol. And every time we give sedations, we need to assess the level of sedations. And normally we are targeting at the 4, okay, Ramsay Sedation Assessment Scale 4, which is just patient will brisk respond to a light glabellar tap, okay, the number 4. So if we start with midazolam, this is old drugs. That's the most common drugs that are used for sedations. So it provides sedation but no analgesia. And the dose is a 0.05 to 0.1 milligram per kilo bolus. The onset is 1 to 3 minutes. Just to remember that if you want to use midazolam for sedations, and it is good that we flush adequately. Not 5 cc, not 3 cc, just flush adequately. And if it's better that if we can put a IV drip with this patient as well, so we can deliver the drug so the onset will be faster. And it lasts for 15 to 60 minutes after single bolus dose of midazolam. And we have, when we look at the non-anesthetic administration of midazolam, a lot of failure rates. Okay, when you use just midazolam alone. So non-anesthetic, sometimes they combine with opioids for morphine. And towards the end, they end up giving a lot. And patients don't sleep, but they sleep afterwards. Okay, half a day, even 1 day. So we have a lot of complications from that. And when they call us for the rescue or failed sedation, they refer to us. Most of the time, we don't attend because they have given a lot of medications. And we scared that the complication will happen if we give some more medications. Okay, so normally we will reschedule to other days where everything is already cleared out. Okay, go back to midazolam. For painful procedures, normally we combine with ketamine or fentanyl. And when we combine, sometimes the requirement is a bit lower. And provide amnesia, mild anxiolysis, and also mild sedation for procedures that do not require full immobility. For example, laceration repair with local topical anesthesia. And sometimes for the MRI itself, it's a bit difficult when you give midazolam. When they are asleep, sometimes they are nodding. There's a movement there, and they have to hold for the scan, so it takes longer time and end up fail. So you have to think about that. And flumazenil is the reversals. The side effects is respiratory depressions and apnea, and when combined with the opioids. And this is what we don't like about when giving midazolam in pediatric patients, which is a paradoxical reaction, including, they're just aggressive, hyperactive, and also inconsolable cry. We don't see this immediately, but There are a lot of reports, in the ward. That's what happens. Even the parents also complains that the child agitated for many hours. So for the pediatric patient, we try to moving away from using the midazolam at the moment. For propofol, it's a common drugs to give, provide deep sedation, but can produce general anesthesia in high dose, and it provides sedation but no analgesia again. So the bolus dose is 1 to 2 milligram per kilo and 0.5 milligram per kilo repeat bolus every 3 to 5 minutes. The onset is fast, less than 30 seconds. It can last 5 to 15 minutes for a single bolus dose, just propofol. So if you want to start infusion, 100 to 200 mic per kilo per minute. From my experience, I like for patient going for MRI, if it's no contraindication for sedation, I will normally like to use propofol infusions. The rate is probably about 1 to 2 milligram per kilo of bolus, followed by infusions about 150 to 170. That's about the range that just right. And most of the patient can tolerate for MRI 1 hour, 1 hour and a half, and hemodynamic is quite okay. So I prefer that compared to dexmedetomidine because the onset is faster. I don't want the patient cry. Okay, patient cry, they start to have secretions, and then suddenly airway obstructed. Okay, and for painful procedures, we combine with ketamine, fentanyl, or remifentanil. We can administer a regional anesthetic and also local anesthetic. But it has a painful on injection. Sometimes we prime with of lignocaine 0.5 cc with the IV access, and then we wait for about 10 seconds, and then we introduce our propofol there. And some patients, in pediatric patients, we just get down to make sure the line is okay. So availability of sevoflurane really helps to establish make sure that the IV access is okay. So adverse effect, which is respiratory depressions, oxygen desaturation, apnea, hypotensions, and absolute contraindication in porphyria, and also propofol should be avoided in patients with a cardiac compromise or hemodynamic and unstable patients. Ketamine is a wonder drugs, and is good for pediatric patients as well. So it provides sedation and analgesia, and for moderate to severely painful procedures, for example, burn dressing. Sometimes we give in combination with a bolus of fentanyl as well. So it's less respiratory depressions, complications than propofol alone. So combination of opioids with midazolam or propofol. So the respiratory depression is very minimal. So the dose is bolus 1 to 2 milligram per kilo, and you can repeat the bolus dose 0.5 to 1 milligram per kilo every 5 to 10 minutes, and we have to see the response. The onset is 1 to 2 minutes and lasts for about 15 to 30 minutes after a single bolus dose of ketamine. So the adverse effect is vomiting, and also sometimes pediatric patient has emergency reactions. So sometimes we supplement for the vomiting. We can give antiemetics. Okay, thank you. Antiemetics 0.15 milligram per kilo, or sometimes we co-administer with the propofol just to counter the post-sedation vomiting. Laryngospasm and apnea occurs rarely, and we can administer propofol and also barbiturates previously, and but they will increase risk of a serious adverse events. So contraindications, in some centers they say this, like age younger than 12 months is not recommended to give ketamine, and in some centers they say absolute contraindication for child less than 3 months. Okay. For ketofol is combinations of ketamine and propofol. So this is used for the moderate to severe painful procedures. So ketamine 0.5 milligram per kilo bolus, followed by IV propofol 0.5 milligram per kilo bolus. Okay, there's a lot of regimes that has been studied and has been proposed for this ketofol. And in pediatric patient, you can give separately like this, or you can put into one syringe, which is 0.5 and 0.5 for each of them, 1-to-1 ratio. So 1-to-4 ratio also been studied, 1-to-5, and up to 1-to-10 ratio of ketamine to propofol has been studied. And but the latest studies are more towards the lower ratios, which is 1:4 or 1:6. That's what the few of the studies recommend. So onset is less than 1 minute and lasts for 15 to 30 minutes after single bolus dose. So we can adjust to our procedures. So repeated bolus of propofol 0.5 mg every 2 minutes as needed, and ketamine can be repeated after 10 minutes, every 10 minutes. So as I mentioned, ketofol mixture, the ratio is 1:1. As one of the studies looking at in pediatric patients undergoing cardiac catheterization procedures, what they found was the ratio of 1:1. This is one of the examples of that dilution, 5 mg per ml dilution for each propofol and ketamine. So you can give the bolus and it can run 50 to 100 mic per kilo per minute infusions. Okay, so these patients from this study successfully undergo these cardiac catheterizations, minimal hemodynamic changes, and also faster recovery as well. So what they mentioned here is if you give the ketofol for longer duration of time, you have to cut down the rate of infusions over time. Probably every 10 minutes, you have to cut down the rate of infusion. If you keep it the same, and the recovery or times to recovery is take longer time. Okay, discharge from recovery take longer time. Risk of vomiting also may be lower because the propofol is administered here, but the risk of bradycardia and hypotension also may be lower. And dexmedetomidine, Presidex, okay, the sedation and modest analgesia with a minimal respiratory depressions is commonly used in diagnostic imaging, CT and MRI. Sometimes we use in combination with propofol for like procedural, like for example, drainage, ultrasound guided drainage as well. And also PICC incisions and central line incision in radiology department. And when DEX used alone, IV loading dose is necessary to accomplish effective pediatric sedation. So can be up to 3 mic per kilo, and the onset is 5 to 10 minutes. And we can administer midazolam as well, so the bolus dose will be reduced. And we can start the infusion 0.5 to 1 mic per kilo per hour if it is often effective. Adverse events, bradycardia, hypertension, and also sometimes hypotension. This is related to how fast we give the loading dose. Okay. And relative contraindication when the patient is dehydrated and also cardiac, hemodynamic instability. What are the options? Intranasal sedation and analgesia. This technique is very useful. Sometimes we use this not in NORA, but I have minimal experience using this, especially intranasal DEX in patient in recovery area in OTs. Okay, sometimes when they're thrashing around, no line just dislodged, so no IV access. Sometimes you have options for the intranasal medication, so you can give dexmedetomidine, and also lots of studies looking at the use of intranasal sedations and analgesia in emergency department when they are doing sometimes fracture reductions, and they do some lacerations, TNS lacerations, and some minor to moderate procedures in the emergency department. So a lot of studies they quote the use of intranasal sedations and sedation analgesia in pediatric patients. So we have the more effective way, we have to use atomizer, nasal atomizers. Okay. So just a quick one, specific procedures for NORA. OGDS, this is highly stimulating procedures. It's a shared airways. It can be diagnostic and also can be therapeutic as well. With the interventions for the night diagnostic, we can in pediatric patients, because a lot of our pediatric patients they have reasons why they need to do OGDS, the diagnostic purposes. They have high risk of aspirations, and they come with a variceal bleeds as well. So risk of aspiration is high. Don't just go for general anesthesia plus minus intubations. And if it's just diagnostic and no risk of aspiration, you can go for LMA. If it's any interventions, sclerotherapy and bending, just go for intubations. And sometimes we have a foreign body removal, stent placement, and also PEG insertions, and also dilatation of esophageal stricture. So all these patients basically have high risk of aspiration. So you want to make sure that after the OGDS, make sure that the physician suck all the air inside the stomach. Hopefully, we reduce the risk of aspiration following the extubations. So lower GI colonoscopy is a longer procedures, and patient can be dehydrated because of bowel prep, and positioning semi-prone and prone position, and it is more painful. The techniques normally in pediatric patient, we go for GA or a deep sedation if possible. If it's a longer time, just tube the patient. Okay. So bronchoscopy, airway procedures. It is shared airway. Most of the time, procedures done in children less than 6 months. It is diagnostic endoscopy and bronchoscopy. The most common one is just to diagnose laryngomalacia, bronchomalacia, and also patient with recurrent pneumonia. So they are not well. Okay. Sometimes the baseline is just they have oxygen. Sometimes they have an IV, CPAP or BiPAP. And we have to look for the dynamic assessment, looking at the vocal cord, epiglottis, and tracheal lumen, and also collapsibility of the airways. So what's the required for these procedures? First of all, spontaneous breathing. So how do we do that? And normally what we do is we use Tiva, propofol, and remifentanil. And if the patient can handle we can just put NPA, and they can do the scope without any intubation or LMA. And we can administer oxygen insufflation through the site of laryngoscope, and also if the patient cannot oxygenate, cannot maintain oxygenation, we can just put LMA or ATT. Technique is GA, Tiva, propofol, remifentanil infusion, plus minus sevoflurane. And topical anesthesia, sorry. Okay. So normally what I do is we ask the physician to administer the local anesthetic as you go. That's the easiest way, because they're just facing the vocal cord, they're just facing the trachea. So it's more effective to do that way. And another thing to prepare is sometimes the patient cannot handle nasopharyngeal airway, you have to prepare LMA. So we have to know this table. Okay, what size scope and what LMA, which LMA size can go through, and the scope can go through. So not every institutions or centers have all this range of scope. They have a minimal, most of the time it's a bigger scope. So this is the limitation of laryngeal mass airway. And this is what we do, and most of the time, I like to combine with a bit of sevoflurane, gas down the patient, make sure the line is okay, because baby this size, they won't allow you to put monitors. You want to put SpO2, take longer time, because you just struggle, just fighting. So normally what I do, just give a bit of sevoflurane, let them come a bit, and then check the line and start the Tiva. And start the Tiva. Normally, I'll go we're using Pitt's user, about 2.5 to 3 mic per mil for propofol, and remifentanil titrate from 0 to 0.5 to 0.1 mic per kilo per minute. That's all. And normally the procedure for the diagnostic procedure will take about 3 to 5 minutes. And if take a longer time, just put an LMA in. Okay, so you can do the bronchoscopy through the swivel channel there. Other things is removal of foreign body bronchus, and this is more challenging. And most of the time, we use GA and Tiva, plus minus LMA or ETT. And the use of rigid scope is quite common. And most of the time, if you use a rigid scope, you need to paralyze the patients. And it's a shared airway, the complication is high, and always have a senior or pediatric anesthetist involved that are more familiar. For the neurointerventional radiology, and most of the time we need to maintain our CPP, we need to maintain hemodynamic stability, CO2, all these things, and normothermia. And the recommended is a GA, and controlled ventilation is needed. That's much easier to do. And normally the procedure take long time. Okay. And for non-interventional radiology, MRI and CT scans, you can, as I mentioned before, you can use sedations for, if no contraindications, the use of propofol and also DEX. So this is the regime that this is from our centers. If DEX is not working, sometimes we can combine with the ketamine a bit, and also or Presidex plus propofol infusions, and then we titrate according to the response of the patients. This is our recovery area, and so recovery area should be standards like in OR. So everything needs to be there, and we have to follow the recovery and discharge protocol like in OR. So patient has to be pre-procedural mental status restored and can be aroused easily. It is stable cardiopulmonary status, cardiorespiratory status, and intact protective reflex and gag and pattern airways, intact motor function, and normally we have to have a responsible adult to accompany the patient go back to the ward. And sometimes we have to do some written instructions, for example, continue oxygens for 24 hours, and also we write down our emergency numbers. This is very useful. In summary, there is increasing requests and need to provide sedation and anesthesia for children undergoing procedures outside familiar our OT environment. And because now the OT is quite crowded, okay, they already full their lists, and some minor procedures can be done outside operating theaters. So this is our challenges to help them out and to make sure that the patient's patient safety. It is important to establish system and protocol to enhance safety and quality of patient's care. And the guideline on patient selections, improve monitoring and management of complication is essential to minimize potential adverse outcomes. And it is important to have thorough understanding about anatomical and physiological variation in children, knowledge of pharmacokinetic and pharmacodynamics of individual drugs, sedations, and understanding regarding the procedure itself, the requirement, and the efficient team communications, and also and everyone must be trained for NORA as well. So for that, I thank you. This is my reference. Okay.
Thank you very much, Dr. Lutfi, for a very comprehensive and interesting talk. And I would honestly say pediatric anesthesia is very heart-raising a field. Can you imagine a tracheostomy without a chain coming down to MRI for sedation? It's not the patient having tachycardia, it's anesthetists that's having tachycardia for whole procedure. I think that's the reason why our niche is so small.